Yeah, thank you very much for the nice introduction. Dear Dr. Arenya, dear Professor Mebasa, dear colleagues and friends, my name is Noemi Glarner, and I'm part of the research group of Christian Müller from the Cardiovascular Research Institute in Basel. And first of all, I'm very happy that this year we have a whole session on cardiac complications after non-cardiac surgery. And as you heard before, treatment of PMI is still very challenging, so today I want to have a look at the impact of beta blockers on perioperative complications in high-risk patients undergoing non-cardiac surgery. So beta blockers are broadly used in patients with cardiovascular disease because they are known to decrease myocardial oxygen consumption by reducing heart rate and contractile force. Pilot studies have shown conflicting results regarding the use of beta blocker therapy in the perioperative setting. Early trials showing benefits were later retracted due to likely scientific misconduct, and a later large trial using a rather unconventional rapid initiation of beta blocker before surgery showed a reduction in MACE, but an increase in all-cause mortality. So we can say that there are still some controversies remaining regarding the possible benefit of the perioperative use of beta blockers. Therefore, we aimed to evaluate the impact of perioperative beta blocker therapy on the incidence of cardiac PMI within 3 days after surgery and on long-term major adverse cardiac events within 365 days in high-risk patients undergoing major non-cardiac surgery. For this purpose, we included consecutive high-risk patients undergoing major non-cardiac surgery at the University Hospital in Basel and at the Cantonal Hospital Aarau, both in Switzerland, and these patients received active surveillance for cardiac complications after their surgery. Furthermore, they were followed up after 1 year. As our primary endpoint, we defined cardiac PMI as a PMI due to type 1 MI, tachyarrhythmia, acute heart failure, or type 2 MI within 3 days after the surgery. And with this endpoint, we can assess very well the potential short-term risk and benefits of perioperative beta blocker therapy. The secondary endpoint was MACE, and this was defined as a composite of cardiovascular death, spontaneous AMI, acute heart failure, and life-threatening arrhythmia within 365 days after surgery. We used inverse probability of treatment weighting to account for differences in the baseline covariates between patients receiving beta blocker therapy and those who did not. And in brief, this means that for each subject within the study, there is a weight assigned based on the inverse probability of receiving the treatment that the patient actually received. So this results in a pseudopopulation in which the baseline covariates are independent of treatment status. And we constructed these weights for our model using a multivariable logistic regression model with age, sex, BMI, cardiovascular comorbidities, surgical variables, and preoperative medication as covariates. To assess this model, we compared the baseline covariates in the weighted and the unweighted sample by comparison of standardized mean differences. You will see this again later. After weighting, we performed a univariable logistic regression model with cardiac PMI within 3 days as an endpoint and a univariable Cox hazard model with MACE after 1 year as an endpoint. So in total, we included 7,751 patients, and almost 40% of these patients had a beta blocker therapy before the surgery. In our cohort, the patients were in mean 74 years old, and 45% of them were female. As you can see here, patients receiving preoperative beta blocker therapy had more cardiovascular comorbidities like history of coronary artery disease, atrial fibrillation, or hypertension. And as mentioned before, here on the far right, you can see the standardized mean differences for the baseline covariates. And as you can see, these numbers are all very, very high. And while there is no clear consensus on what value of SMD indicates a relevant difference between the baseline covariates, some studies have proposed that an SMD of above 0.1 may denote a meaningful imbalance in the baseline covariates. So now here on this graph, you can see the SMD in the unweighted sample in red, and in the weighted sample in green. And as you can see, with our model, we achieved a good balance in the baseline covariates. So now looking at our endpoints, 812 cardiac PMIs occurred within 3 days after surgery. And when we compare the patients receiving beta blocker therapy to those who did not, we did not see any difference in the occurrence of cardiac PMI with a weighted odds ratio of 0.99. The composite MACE endpoint after 1 year occurred in about 9% of all patients, and more than 10% of all patients died after 1 year. Here on this graph, you can see the weighted cumulative incidence curve for MACE within 1 year. Again, in red, the patients not receiving beta blocker therapy, and in green, the patient receiving beta blocker therapy. And also here, after 1 year, you can see that there is no difference between the two groups, with a weighted hazard ratio of 1.07. The same is true for all-cause mortality within 1 year. Of course, some limitations merit consideration. Unfortunately, we had neither information on the dosage nor on the duration of the beta blocker therapy before the surgery. So to conclude, in our patient cohort, we could not see any difference in cardiac PMI between patients receiving beta blocker therapy versus those who did not, suggesting that continuing beta blocker therapy perioperatively is safe, but was not associated with any benefit. Also, after 1 year, we saw no difference in MACE between patients receiving beta blockers before the surgery versus those who did not. Thank you.
Thank you very much, Noemi. Then you see we could be a very good soccer player and a very good researcher. Very good. Questions? Can I start with one? You followed the patient for 3 days after surgery, is it correct? The heart rate, was it lower in patients with beta blocker compared to those without beta blocker?
That's a very good question, but unfortunately I do not have this information at the moment.
No problem. Yeah, we have a question from...
Sorry, I think I just missed, but I'm Hyun-Suk Yang from Korea. And among your study subject, how many patients got the coronary angiography, and how many patients have a positive result and stent implantation?
Sorry, can you repeat?
How many patients among your study subject, the PMI, coronary angiogram, and intervention?
So very little patients of our cohort get a coronary angiography. I think it's below 10% of patients that get this intervention. Sorry?
So we should consider if the patients are sometimes their condition is not good to go to the coronary angiography, I know, but if there is some suspicion of a myocardial infarction, usually we are trying to do at least have some resolve some critical revascularization using the stent. So I'm just wondering how much the percentage of your PMI patients have a angiography. So it is very rare.
Yeah, I think you also need to consider the setting that you are in, because these patients just come from a major surgery, and many of these patients cannot get a dual antiplatelet therapy because of their surgery. So sometimes maybe the cardiologist would advise to get a coronary angiography, but it's not possible. And as I said before, very little patients, I think below 10% or even lower, really get a coronary angiography.
Okay, we need to move on, and just for the young investigators, answering to the question is also very important for the award.